Thank you guys for joining me today. Just want to double check. You guys can hear me okay?
Okay. Yes, we can.
Awesome. So I'm Natasha. I am a PGY3 adult psychiatry resident here at UT Dell, and I'm going to be talking to you guys about psychiatry and why I fell in love with it, why I chose it. But I'm going to start off a little bit with my journey in medicine. Picking your specialty is such a long road, and y'all are more at the level of like thinking about med school and thinking about the MCAT and all that kind of stuff. So I'm actually going to start there. And then I'm going to kind of move to what I love about psychiatry, what is difficult about it, and what I plan to do in the future and how diverse of a field it is. So I'll get started. I'm going to share a little bit about my background. So my journey, I'm actually an immigrant. I moved here from New Delhi. I'm from India, and I moved here at a really young age. I actually came here when I was 9, and I turned 10 right when I got here. So I immigrated from there. And so most of my schooling was back in New Delhi. When I got here, I did middle school and high school in Houston. And then after graduating from high school, I attended Baylor University in Waco. I really wanted to stay in Texas. And I was between UT and Baylor, and I ended up going to Baylor just because I really, really wanted to go to a school that had small classroom ratios and gave me more attention in terms of like getting to my goal of going to med school. So that's kind of how I came to that decision. I had a really, really hard time getting into med school. And so, you know, you probably heard a lot of doctors on here talk about how they got into med school. For me, it was incredibly difficult. I am not a good test taker. I actually took the MCAT 3 times. I'm going to tell you more about that as I progress and tell you about my journey. But I was incredibly blessed to apply directly my senior year from Baylor, and got accepted to several out of school states, and then got into one in Texas. I got into TCOM. It's like a acronym that we use for Texas College of Osteopathic Medicine. And I went to medical school there for 4 years. That's in the DFW area. So it's a Dallas-Fort Worth area in Texas. And then after graduating from TCOM, I started residency in Austin at UT Dell Medical School, which is one of my top choices. And right now I am a PGY3 there, which is a 4-year residency training program. And I'm in my 3rd year, almost halfway through my 3rd year. So maybe about like 18 months of residency left. So that's where we're at. So that's a little bit about my journey, and I'll keep sharing a bit more details about how each step kind of went. So undergrad, like I said, I went to Baylor University. I originally started out as a neuroscience major and a psych minor. And I realized it was a little too hard to complete that with my prereq requirements, along with also being in their honors program, which was a great text minor. And so I switched to a biology major, got all my prereqs done for pre-med, and I was also a great text minor in their honors program. But some of the things I really tried to focus on was preparing like my like application for med school. I wanted to be incredibly well-rounded. I wanted to take every opportunity that came my way. I was a tutor at the Paul Foster Success Center, which was one of our tutoring centers. I worked in a research lab and did very bench research, which I didn't personally enjoy. Now I know that. I didn't know that then, but very not research-minded. I did research for my honors thesis. It was bench research for plants. So it's nothing like what I actually want to do in my life. But I just took the opportunity and learned how to do bench research. I think it taught me a lot, so wouldn't take it back. And then I was also, there's a medical student organization that I was a leader in. So I really tried to make my application very well-rounded. Tried to also make the best of the 4 years at the same time. I really did have a really good time in undergrad and fully enjoyed it. I was captain of a competitive dance team. It was a Bollywood dance team, and we used to compete all over the country. I was in a service sorority, and we held these like campus-wide service events where we would make blankets for a bunch of community centers around Waco. And we'd also throw carnivals for the Family Abuse Center in Waco. And so we were pretty involved in campus activities, and that made my 4 years really great. So I wanted to mention that just because, you know, when you look at the focus of getting into med school, it just looked like I was doing that all the time. That wasn't true. I definitely had a really fun time during my 4 years. Okay, so the struggle, like I mentioned, very untraditional route to getting in. I definitely struggled a lot, and I'm not ashamed to talk about it just because back then I was really ashamed that I was someone who was struggling to get in. But like on the other side, it doesn't matter at all, because really those numbers, like no one's ever asked me, not a single patient. I have like 150 patients in my private clinic, and not a single one of them has ever asked me like my MCAT score or really anything about my past. So those numbers that seem so important then, they have no significance in the patient care that you can provide. So if I could tell you guys anything, is getting in, that's all it is. Like that number is not going to define what kind of doctor you're going to be. I'm not a great test taker. I never was. I had a lot of test taking anxiety. I was prepared to struggle through this because when I did take my SAT, I struggled a lot with test taking anxiety. And so I kind of knew this was going to happen to me when I took the MCAT, which is why, like, going back when I was mentioning I really wanted to prepare my application, is because, you know, I knew this would be something that wouldn't be like a shining star when they looked at my paperwork. So I really wanted to make sure that the rest of my application was stellar. So, you know, I could explain, you know, I'm really interested in medicine and I love it. I'm just not a good test taker. And so looking back, I did struggle to it. I did want to go directly. So a lot of people take a break, or they do, you know, like they do like maybe like a year of like a master's or something else. I really wanted to go directly, just because I was an immigrant and I had a lot of loans from Baylor, and I didn't know how to pay those with like the money that I had back then. And so I was like, I really need to go directly so I don't have to start paying my Baylor loans. And so for me, it wasn't much of a choice, I felt. I wish I could have taken some time off. I think it's great to take a year off. If I could go back, I definitely would do that. If finances allow, of course. So for me, that was a difficult thing. I took several MCAT courses. For the first summer, I took a Princeton review, group review. And then the next summer I took Kaplan, which was more of a one-to-one review. And for these, like, they were definitely very expensive courses, which, you know, taught me very quickly that if you're not a good test taker, medicine is expensive. And I luckily and you know had a lot of family support that helped me get through these classes financially. But you know, it is really hard. I definitely think it can be done alone, but I needed all the help I could get, and I took it. So I scored pretty decently on my first test. The second test was awful because I actually ran out of my second test due to a lot of anxiety. I canceled that one. And then I took the third one right before applying, so like the summer before applying, and I got the same score as my first MCAT, which is so disappointing. Because I really just wanted to boost my score up. I really wanted to go to school in Texas so I could stay close to my family, and that was like the big reason for me taking it again. But do not lose hope, because I still applied directly and got into several out-of-state schools and one Texas school, as I mentioned. So DO versus MD. So I am a DO, a very proud one. I did want to go to a DO school, which is very untraditional. I just really liked their philosophy regarding just like the holistic approach. I really wanted to learn OMM, which is the manipulation technique we use for like back pain or injuries that I can still practice on friends and family. And I just really liked that they were more, they just like really like look at the application fully rather than looking at test scores. And I knew that was my weakness, versus I felt like MD schools would sort of put my application aside because it probably didn't have the number that they were looking for. I don't think that's all of MD schools, but I just wanted someone that would look at my application fully. So when I came to the decision, I did pick a DO school. I picked TCOM, and I really, really liked it there. I did struggle a lot through my first 2 years, which are very academic. And they're all very like, memorize a bunch of stuff. They're like anatomy lab. And what I mean by a lot of difficulty is there are a lot of tests. I mean, I literally felt like I was a professional test taker. And we'd have a test every week, and you just had to cram and take them. And I did really well, so I wouldn't necessarily say it was a struggle like the MCAT was, because it wasn't a standardized test. It was just like regular tests. So that was fine, but it just wasn't fun, is what I mean by difficulty. Like, I wasn't having the time of my life doing it. And then when the second 2 years of med school came, those are the clinical rotation years. I really shined through those years. I loved it. I learned a lot. I'm just a very hands-on kind of like in-person learner. And I felt like I finally got my chance to show what I knew and what I could do and interact with patients. And I was like, wow, all this doubt that I had my first 2 years about being a good doctor, like it was so based on like test scores and studying skills, and it's nothing like what it is in real life. So I will be honest and say that I didn't come in loving psychiatry or wanting to do psychiatry. I really wanted to do something that was, and we use this term a lot, it's fields with long-term relationships. So what do I mean by that? They're specialties that are basically going to allow you to follow someone over time. So build a relationship with patients where it's not a one-time, like an ED, where you see a patient and you discharge them, you're probably not going to see them again unless they're really sick and they keep coming back to the ED. I wanted something where I could see someone for a decade and then see their child. I really wanted that kind of life. And so I wanted to do pediatrics or family medicine that would allow me to have that continuity of care. But as soon as I got into med school, I attended a seminar about psychiatry, and I was like, this is really interesting. And I could see myself doing it, and it has that long-term connection. So I was like interested in it. During my third year, when I was doing clinical rotations, I was pretty much like between OB, GYN, because I actually really liked the balance between procedures and clinic and surgery for that one. I was interested in family because, like I said, I wanted long-term, and then I was also interested in psychiatry. And it kind of came down between those three for me. But ultimately, I chose psych, as you guys know, and I'll show you a little bit as to how I got to that decision. So why psych? I want to be really honest. I'm very biased because I love my field. I love mental health and I love psychiatry, but I picked it because of how I felt on my inpatient rotation. I woke up every morning excited to go into work, see my patients. I loved that I could be in the room with my patient for however long I wanted. There's like not much time restriction in psychiatry, versus like when you're in surgery and stuff, you gotta like keep moving, keep doing. This was just like I could get to know them. I loved the neurobiology behind it, especially like learning about the dopamine pathways and learning about like how these drugs can sort of alter serotonin levels and how they work to alter psychosis. Like I was just so fascinated by the neurobiology. The other thing is when I was thinking about family medicine and pediatrics, as I mentioned, I realized I really wanted to specialize. And everybody has their own reason. Is, general medicine, I think we need more people doing it. But for me, I really just wanted to be an expert in one field. I didn't think I was someone that could have a broad set of knowledge. I think what I'm really good at is knowing a section of things and just knowing it really well and feeling competent in it. So I want to specialize. That also helped my decision. And then my own experience with my own mental health, which I'll talk to you more about. The ultimate reason is my last 4 reasons, as you can see down there, is I was really fascinated and sort of discouraged by the stigma of mental health in my culture and my background. Like I said, I'm an immigrant from South Asia, and I just realized that psychiatry wasn't super respected in my culture, my background. I have my own battle with that. And so I was like, this is something I'd like to be a pioneer in changing. And then holistic care, I'll talk a little bit more about that, but I didn't want to be someone that just talked about drugs and how I can change pharmacology to make someone better. And I love that in psychiatry, it's like not just drugs, it's like therapy and diet and exercise. And I can like make people like a full individualized treatment plan. And I love that. I also love that there are different settings, like inpatient versus outpatient and ED, like just every day was different. I loved it. And then the last is work-life balance. So when it came down, the last two I came down to were between OB and psych. And I realized that I really, truly wanted a good work-life balance. I have a second career, which I'll talk to you a little bit more about. And I really wanted to keep that going. So ultimately, that's why I chose psychiatry. Not a single day that I regretted it. Okay, talking a little bit about my mental health. So it's a little bit personal, but I absolutely don't mind you guys messaging me later and asking me more about this. I'm so open about my mental health. And that's with time and just being a pioneer of changing the conversation around mental health. I think I'm very comfortable talking about it. But as I mentioned to you guys, I took the MCAT 3 times. I put a lot of pressure on myself to go directly. Like I said, looking back, I'm like, I shouldn't have, but I just felt like I couldn't financially take a break. I just felt like all this like pressure as an immigrant to perform at this level that was maybe unrealistic. And I think I put that on myself. And so the application and taking the MCAT so many times, like running out during my second one, having to cancel it, like it really took a toll on me, my physical and mental health. It was during that time that I actually had my first experience with psychiatry. I went down and started some therapy around this test anxiety that I had, or this need to like not fail and go directly, and feeling like if I didn't succeed, I would be a failure of some sort. And going into therapy was super helpful for me. Actually, it's what encouraged me to apply directly, even though I didn't have like the perfect MCAT score or even like near the average. And so at the end of the day, I felt like, sorry about that. I felt like anxiety was something I struggled with for most of my life. And so I was like, okay, that's fine. I'm just gonna take therapy, do it. And then it was like a whole other person after. It was never addressed in my culture. It was never something like that any of my relatives would have told me to do, even though they saw that I was like anxious all the time. So I think it's just something that's not talked about. And I was like, this is so interesting. I never considered psychiatry at that point. So people were like, oh, well, at that point where you're like, I'm gonna be a psychiatrist. And I was like, no, I never thought that, not once. But when I got into my rotation and I saw that people were getting better and I saw the stigma again, I was like, I could be someone that really opened this conversation. And that has been my goal since I picked psychiatry. And if any of y'all follow me on Instagram, it's all about an open conversation, changing the stigma, talking about mental health, and just changing this idea of not talking about it. So what is psych? Finally, what I get to do like the rotation stuff, but I'll start out by telling you what it includes. So my job is basically doing medication and treatment plans for all these things. What do I mean by treatment plans? So I want to emphasize this, and if you could take away anything from the next 20 minutes, is that psychiatry is not giving a pill and walking away. It's not giving medication to people who are struggling with severe mental health conditions. It is a treatment plan. It is so like collaborative and just involves so many parts. And I'm going to talk a bit more. But what do I do? Like, what do I treat? Mostly what I treat is depression. It's like the main thing I see. I do anxiety, those two are also treated by primary care physicians. And so I look at that and I'm like, okay, so those are, if primary care physicians aren't able to treat depression and anxiety, then they usually come to me. Then mostly I do bipolar and schizophrenia. Those are like our black box. No one else can really do those as well as psychiatry can. I do a lot of severe OCD. I treat delirium in hospitals, do a lot of substance use, alcohol, opioids, stimulants. I do personality disorders. If you guys have heard of borderline personality disorders, see a lot of those patients. I treat grief. The big one, medical conditions that mimic psych. So someone once asked me, they're like, what is the purpose of psychiatry? And I said, what we can do, what no other specialty can, is we can evaluate a patient and tell you if this is something that's medical or if it's something that's psychiatric. And that is a really cool thing to be able to do, because a lot of medical conditions can look like psych. And I'll give you guys an example. Like someone who takes high dose steroids can look like they're manic or psychotic, but really it was the steroids. Someone with like thyroid problems can look really depressed, but it was their thyroid. So one of the things that we do really well is differentiate those. Psychosis. So that could be psychosis from drugs, psychosis from bipolar, really any psychosis, and then agitation. So when patients are agitated on drugs or not able to function due to catatonia, etc., then we treat the agitation as well. So that's a good overlap of all the stuff that I treat. There's a lot more, but this is just like the main stuff. Okay. So like I said, medication and treatment plan. What does that include? So I do a lot of psychotherapy. I'm not a psychologist, so I don't do just therapy, but I do learn and train in therapy. And I have a lot of therapy patients that I do medication with plus therapy with. I have patients that I do just therapy with, just medicine with. So it really depends on what your patient's looking for. Another thing I love about psychiatry is, like I've mentioned, like when I say the word holistic, I mean like I can come up with their individualized treatment plan. So I'll tell you some of the things that I'm trained in through my residency. I learned cognitive behavioral therapy, which is a type of therapy to help with anxiety. I teach a lot of breathing techniques. I'm trained in trauma therapy, which is a thing called CPT. There's a book for it. It's called cognitive processing therapy. I do a lot of psychoeducation. That's a fancy way of saying I teach people how like lithium and how antipsychotics work in their body, and then teach them how to take it and be compliant with it. I do a lot of med versus therapy consultations. So trying to figure out if they need one or both, or how we can best treat someone. My personal interest and what I hope to do in the future is something called nutrition as medicine. If you follow me on Instagram, I talk a lot about how nutrition and food is medicine and how it can completely change how someone feels, and specifically with like depression. And that's honestly how I healed a lot of my anxiety, was through food. So that's one of my personal interests. Movement as medicine, I think that's equally like tied in. And I actually prescribe patients like walks and exercises. And I don't know if anybody else does that or any other specialty, but I love doing that. I love putting that as part of my plan. And people actually get better on it. That's the cool thing. And if they really trust you, then they actually go and practice these changes. And it's so cool to see them get better. Not just from that, but like everything that you do. And then dialectical behavioral therapy. That's a special type of therapy for patients with borderline personality disorder. So I'm also trained in that. Let's see. Okay. Settings. So like I mentioned, it's such a diverse field. ED, not my thing, but very cool. You can be an ED psychiatrist. A lot of acute stuff, a lot of drug use, a lot of agitation. Inpatient psych is my favorite personally, because I think we see our sickest patients in patient psych, and I love the idea of educating. So psychoeducation is something I love doing. And so when a patient comes in and it's their absolute very first time experiencing psychosis, and they're so scared and their family is so scared, and you're trying to explain to them what's going on, you get to be the person that that basically tells them how they're going to get better and how they're going to stay on the medicine for the rest of their life. And it's such a scary and intense conversation. But once you get good at it, you can really make a difference in their family's life, especially if there's a stigma. That's probably why I love it. Outpatient clinic, I think it's really great if you want to build long-term relationships, and I hope to have a little bit of that because it's always what I wanted. It is quite slow-paced, so I didn't like it as much as I thought I would, but it's definitely something I want to incorporate. Consult liaison, very cool. You get consulted by other medical specialties if they think that something is psychiatric is going on, or if they can't figure out why someone's acting a certain way. People work in detox centers, they do rehab. ECT is one of the big procedures that we can do. It's electroconvulsive therapy to help patients with severe depression that have failed medication and therapy. Some of us do forensics, and then also within psychiatry is adult, child, and geriatric. You can specialize in child and geriatric as well as fellowships. Okay, I wanted to talk a little bit about moments in psychiatry because I think it'll truly show the passion I have for it and what the field is like without you guys like coming into a hospital to see it. So there's some beautiful moments in psychiatry, like helping someone who had severe depression after something that happened to them and seeing them get better. Educating a family from a different culture about mental health and kind of opening their eyes as to how someone can get better with medication. Having like a really sick psychotic patient who didn't even know like the date or their name leave the hospital after returning back to their usual state. Like it's such a beautiful moment because then you see them so sick and then you see them so much better after. One of my favorite things to do is teaching a family about bipolar disorder. It's such a hard thing to look at someone and tell them you're going to be on medicine for the rest of your life, and it's your family's job to sort of make sure that you stay on it. And that conversation, I mean, it's not that simple. It takes a long time, and if you can do it well, you can kind of change the trajectory of that patient's life. Breaking the stigma. I love talking to patients who had like religious or cultural stigmas, whether it's like South Asian or not. I've had a lot of Hispanic patients that had this, and sitting down and talking to them about even like using a translator or bringing in like a pastor or like bringing in a religious leader and sitting down and really explaining to them how we can help them through psychiatry. It's really beautiful when they finally can see that they can seek help. Inspiring others to talk about their anxiety. I think I'm a little biased about that one because I struggled with anxiety, but finally getting to see a high functioning individual open up about the anxiety that they've been hiding. It's really wonderful when they get better and they're able to talk about it. Being the first person to hear someone's trauma. Like I said, I am trauma. All of us in my program are also trauma therapy trained, and being that person where you get to hear someone's trauma that they've never had the courage to share, and helping them get better through therapy and medication. That's a really cool way to kind of see them transform into who they used to be or who they want to be. Being there for someone who's lost their family and friends due to addiction. So I see a lot of patients that in rehab and in the hospital that literally lost any support because they're just so reliant on cocaine or meth, and you're literally the only person that they have still rooting for them. And it's so hard to be like, you know, they let you down in the sense that like they go back to using, but like if you know that the medicine behind it and the chemical interactions behind addiction, then you're that one person that understands why they're acting that way, and they get to rely on you and they get to open up to you, and it's so incredible when you get to educate their family as to why they're acting that way or why they themselves are acting that way. So very cool things that I get to do. I know I've used beautiful a lot just because I think, like I said, I'm just so in love with my field. And I don't mean to use that word repetitively. It's just, I myself have had such touching moments with my patients that and I'm not afraid to be vulnerable with them. I'm not afraid to be in the room with them and tell them how it made me feel, or crying with the patient or their family members, or just being there for them. I think it's why I chose this. And if any of y'all end up in this field, I hope that you get to have some of these moments. But I do want to also be honest about some of the downfalls of it. I don't want to be a person who's just walking away with this picture of everybody getting better. A lot of patients don't get better. They're chronically sick. They're homeless. They end up on the street. They stop taking their meds. There's a lack of funding for homes, services, rehab. Unless you have insurance, you don't have access to rehabs. There's a lot of like ATCIC and stuff for Texas is like ways to help the patients who don't have insurance for mental health, but all those services are contingent and sometimes people don't use them and they're very busy, and you can't always change people's social status. You can't change if they're homeless. You can't change their situation if they live in a family of abuse, or sometimes it is heartbreaking. And I think we kind of glaze over that when we talk about psychiatry, but there's a lot of things that I can't change, no matter how holistic or caring my plan is. I have a lot of limitations as a psychiatrist, and I want to be honest about that. The other thing is that there is a shortage of us in Texas and all around the country. So you are always going to be, you can look at it as a positive and be like, well, you always have a job. You'll always, be well paid. But it also means that you'll be very busy. It also means that, you kind of have to make that decision as to what you are willing to see. Are you going to see uninsured? Are you going to see insured? Are you going to help the people that really, don't have access? So are you just going to, choose a specific population? For me, that's a battle for my future as to what I want to do with that. So malingering patients, what does that mean? They're usually patients are looking for a shelter. So you'll see that a lot in the ED. Really hard to decipher if someone's just saying that they're suicidal or if they're looking for shelter. That's something that I spent a lot of time getting trained in. Agitated patients. So sometimes, like I have had very, very aggressive patients, and in the lockdown unit that there is police escorts and such. And I do have techs all around me when I go see these patients, but it is kind of scary sometimes. And this one time, this woman who was psychotic kind of lunged at me, and luckily there's a police officer right next to me that pretty much grabbed me and protected me. But it can be kind of scary as like a small 5-foot woman. I've never been hurt, but that is always a risk if you're not careful. But we do get trained in it, so I don't want to make it seem scarier than it actually is, but it is a reality. And then last but not least, it can be very emotionally fatiguing. I've heard stories of trauma and seen things that have really affected me. So you kind of have to be able to separate that. And I just want to throw it out there. Despite all these things, I love it every single day, and I hope to sort of be the positive light in my patients' day or even like their week, despite their social status or situation that I can't change. What I can change is the 30 minutes that I give them. So I try to see it with that perspective. That being said, I just kind of want to, as we kind of like head towards the last few, I want to do a quick case presentation. I thought it'd be really fun to walk you guys through like a funny case that I had. Okay, so 20-year-old male with no significant medical history outside of some depression. He's treated with low-dose Prozac. I saw him in the inpatient unit, in the lockdown unit. So I read about him and I look over and he's actually on TV. And I'm like, what is happening here? Is this my patient? He was found naked in the Barton Springs pool. If you guys are familiar with Austin, it's kind of a famous sort of kind of like a man-made destination pool here. And after breaking into a home near Barton Springs pool and stealing a popsicle. And I'm like, this is going to be interesting. This is before I walk in. I have a med student with me and they're like, this is going to be very interesting. This is the case you want to see. So I go in the lockdown unit and I sit down with him, and he's like this really well-dressed guy just sitting on his bed, just like laughing and smiling, and tells me that there's nothing wrong with him and he'd like to go home. He really denies everything, depression, anxiety, and he kind of laughs at some of my questions. He's like easily distracted. kind of talking to me about, he tells me that he's like he's a gamer, and he's also like one of those super tech people that came here from San Fran to start a company with Apple and Amazon. And I really honestly could not tell if he was like telling me the truth or not, like if it was a delusion or if it's reality. And I look at the chart and there's like a little message from his parents. And it turns out he is like super tech, and he did come here for a trade for Apple and Amazon. And I'm like, very interesting. So what would you guys do next? And I kind of wanted to do this with like you guys answering in the chat, but I feel like that might take longer than I can like probably figure out how to do that. So instead, I'm just gonna like reveal the answers. Let's see. Okay, if you guys want to throw in things into the chat, go for it. I just pulled it up.
We're gonna let them. We're getting some answers that are narcissistic, personality disorder,
DID.
Yeah.
Okay. Okay. What about throw in something that like maybe like you would think for someone who was easily distracted, laughing.
Got some ADHD.
Yeah. Okay. Okay. You guys, I'm gonna reveal the answer. Okay. So what would you do next? Okay. So the first thing I want to do is call the parents. He's young, so that means he's got some parents that are probably going to be involved in the care. The next thing I want to do is labs. So like I said, what is a psychiatrist? It's someone that can differentiate if something, that's funny, the popsicle. It's someone who can differentiate if something medical or something psychiatric is going on. So labs are a big part of what I do. A drug screen. Someone mentioned marijuana use. So I want to know if this is like him on meth or if this is just like something else is going on. I want to file. So filing, I think it's a little hard to explain, but basically psychiatrists have the ability to legally keep someone in a psychiatric hospital in some states. And if we think that they're not, that they're a threat to society, or if they might cause harm to themselves or others, then I can file to keep them in the hospital. What kind of labs are run in this scenario? So usually our lab panel includes like a CBC, a urinalysis, exactly, a CMP, a TSH to check for thyroid, a UDS, which is a drug screen. We also like to check for like lipids. We like to check for diabetes. So in Texas, it only requires me to sign it. So one physician. I wouldn't do genetic screening at this point, no. At this point, I would just do basic labs to see if I feel like anything is going on. For instance, like the biggest thing we think of with this is drugs. So I would want to rule that out for sure. If someone's acting this way, I'm suspicious of drugs. So UDS was positive for marijuana, but I wasn't super concerned about that because he was acting a little, way more off than just some TSH. His labs look stellar. I called his parents, and they tell me that he's been acting this way. He moved from San Francisco back to Austin because that's where he lives. That's where they live. And basically, he hasn't slept in more than 10 days. And he came here as part of a tech project, but then started telling them that he's going to buy Apple and Amazon instead of doing some work for them. And instead, he's going to take over the companies and do a backlog to the computer and do some kind of trade and start to take over the company. Now you guys give me guesses. Okay, I see one I like. Yes. Yes. Okay, so this is mania. Mania is a part of bipolar disorder, and it's when you're not sleeping easily distracted, start to have delusions of grandiosity. So now he was a tech person, like he did have this contract with Apple and Amazon, but like he thought he was going to own them, and he thought he was going to like take over the companies, which was obviously a delusion. So this is mania. And so his laughing, his distractibility, his not sleeping, his delusions of grandiosity, I look at my message and I'm like, well, what do you think this is? And they're like, this is mania. This is classic mania. So here you go. This is the answer. Okay, so differential. In med school, when you guys do med school or nursing school or whatever profession, there's always going to be this idea of differential. What is a differential? It's all the possibilities that I think of when I walk out of the room. So I was like, okay, this could be depression, anxiety, bipolar, schizophrenia, the 4 most common mental health diagnoses. And I'm thinking bipolar, mania. So here we go. This is a little summary picture I found. So I wanted to include some pictures. And this is one I found that felt like really showed mania. There's a mnemonic that I learned in med school. It's called dig fast. Distractibility, indiscretion, grandiosity, flight of ideas. What is flight of ideas? It's when they can't stay on one topic. So this guy told me about his t-shirts and his grandfather and San Francisco and his love for vegan food all in one sentence. And I was like, what? Activity increase, so like easily distracted, pacing, sleep deficit is a big one, and then talkativeness. This guy was talking a mile a minute, telling me how he wanted a popsicle, telling me how he was at Barton Springs and how he took off his clothes and why, and how the police came, and how this is completely and utterly crazy that he's in a psychiatric hospital and I should just let him go. And I'm looking at him and I'm like, okay, I need to file on this guy because he's clearly sick. And I'm gonna have to sit down and kind of explain to him and his family what's going on. So I'm gonna give you guys a little bit of history about bipolar. So for men, because he's a male, I'm gonna talk specifically about males. Usually their diagnosis comes around early 20s. I do see a lot of cases at 19 and 18 though. So this is like the prime time for them, early 20s. Sometimes I do see late 20s as well. For a female that's later, it's like late 20s, early 30s. Bipolar 1 and bipolar 2 are very different. So bipolar 2 will probably only have like maybe 1 or 2 of the dig fast that I showed you guys. And bipolar 1 would probably have a ton. But the big discerning criteria between bipolar 1 and bipolar 2 is that bipolar 1 patients usually have had the symptoms for more than 4 days, specifically the sleep criteria. So they haven't slept in 4 or more days, or they've only slept a few hours in 4 or more days. So he met criteria for bipolar 1. The other thing that made me think it was bipolar 1 is because these delusions were so engrossed that he had like emailed like people all around the country about how he's going to own Amazon and Apple and this trade, and just like all these kind of bizarre delusions. And so I wanted to look for family history. Seems like no one had any. And it seems like he didn't have any other psychiatric history in his past either. So this was what we call a first break mania. It's the first time he's had episodes of mania, which leads to a diagnosis of bipolar disorder. Okay. What is a treatment for bipolar disorder? Lithium is the gold standard. That's a fancy phrase of using the most researched and the best for long-term care. So I did start the patient on lithium. And then antipsychotics can be used while they're inpatient during their acute time to help them kind of help the delusions that they're having. So those can be 2 ways. They can be oral medication, or they can be a monthly injectable called an LAI, which is fancy thing of basically saying I'm giving them the medicine in an injection. So I put a little example down here for you for Invega Sustenna, which is the medicine I gave this guy. Invega Sustenna is basically a injectable in place of oral Invega, which is an antipsychotic that we use, and there's different available strengths to it, and I administered his in the gluteal. The reason I chose an injectable for him versus an oral is because one, he didn't like oral medication because he felt like his family felt like he wouldn't be good at taking it, and he's already taking the lithium orally. But also, he actually had a legal case against him for the place that he stole the popsicle from, and I met his and his lawyer recommended to him and his parents that an injection might look like he's going to stay stable for a long time, so his legal case might look better. So it was an exception to the LAI. I usually only do LAIs for patients who are like really, really bad at taking their meds, but he was sort of an exception for his legal case. And then this was in the hospital, but he actually became my regular patient in my private clinic, and I got to follow up with him, and he got a lot better. Hopefully went back to working in tech, but he moved back to San Francisco, so I don't know exactly what happened. But very cool case, and someone I'll remember for forever just because he became my patient, and I gave one of my first injections for him. My last slide is just a little bit about what I want to do in psychiatry. I'm gonna try to leave like 5 minutes for questions, but just wanted to end on a positive note. I want to do inpatient psychiatry. That's what my case was, so inpatient. It's like classic mania, is very inpatient. I'm really interested in neuromodulation and the stigma behind it. So electroconvulsive therapy is one of the big procedures that psychiatrists can do. There's plenty of neuromodulation now, but ECT is one that I'm interested in doing for very, very sick psychotic patients or catatonic patients, for long-term bipolar or long-term depression that's not treated with medication. And I did my ECT month, and I absolutely loved it. And I think there's a lot of stigma behind ECT because of the movies that came out in the 80s, and it being a torture sort of a situation versus really helps people. And I hope to, since I'm so interested in stigma, I hope to do a lot of ECT. But my long-term goal, like I mentioned, is nutritional psychiatry. And so hopefully if I ever have my own clinic, I get to do more of that, is food as medicine. So this is pretty much my presentation. I'm gonna quickly just like go back to the case presentation to see if you guys have like any notes about the case presentation. I'm gonna try to scroll up through these and try to answer some of these for the last 5 minutes. And then if you guys have like questions about medicine or med school or psychiatry, even the case, you guys can message me. This is my handle. Okay, there we go. That's my handle on Instagram. You guys can message me. Just tell me that you met me through here, because sometimes I'm like a bunch of creepers, so I want to like make sure it's not a creeper and it's one of you guys. And so if you guys message me, I can answer those questions. But I'm gonna try to scroll back and answer some of these in the last 5-ish minutes. Okay. Okay. Let's see. A urinalysis. Yeah, that was a really great suggestion. I could do a urinalysis. Does it take 2 physicians to file? No, in Texas, it only takes 1. And being a psychiatry resident, I can file. For me to hold someone for more than the 30 days, I need 2 physicians, but not to do the first hold. The first hold, I can do it by myself, which is pretty cool because I've gotten really good at doing legal cases and going to defend myself in court and all that. Genetic screening, I usually do a genetic, I do a family history more than a genetic screening. Family history is really important in psychiatry. There are a lot of genetic testing out there to see what medicine will best help patients. Those are still pretty new and they don't dictate clinical reasoning just yet. So I tend to stay away from them because they're very expensive and sometimes not that useful. So let's see. Does thyroid problem? Okay, so hypothyroidism can cause severe depression. Hyperthyroidism can cause anxiety, but in severe cases, it can actually mimic mania, crazy enough. Because hyperthyroidism leads to not ability to not sleep, distractibility, severe anxiety. It can look like mania, and I have seen that. Hormonal imbalances. Yeah, so that's why like if sometimes we're not able to find out what's really going on, we do like a metabolic panel. And then that's in like cases in like the hospital where we're really not able to figure out what's going on with someone. We're like, is this some kind of cortisol imbalance or that kind of thing? 10 days. Yeah, so yeah, like people who are manic can go several days without sleep, or they'll only sleep for like 2 hours, and the rest of the night they'll be up cleaning, emailing, working on projects. The classic phrase that we use is goal-directed activities that don't make sense. So doing things like moving furniture or emailing people from the past, or like answering all these calls that don't make any sense. And it just all looks like they're very goal-directed, but they're actually doing things that don't make sense. Delirium. The best way to check for delirium is actually to see if they're alert and oriented. Patients who are delirious usually can't tell me the day and the date. And that is really, really common in the ICU for very sick cancer patients, COVID patients. So I do a lot of delirium analysis, and the best way to do that is to test their concentration and their alert and oriented level. Borderline personality or disorder, that one usually we see a lot sooner. We start to see a lot of manipulative behavior, a lot of difficulty with relationships. It's something that needs a lot of therapy. And like I mentioned, there's a specific therapy that I get trained in. It's called dialectical behavioral therapy. So schizophrenia or schizoaffective were both on my differential for this patient because he was psychotic and bipolar, but it seemed like because it was so specific for bipolar, it looked more like bipolar. But schizoaffective was definitely something we considered for him. Yeah, there were delusions. Let's see. Can this happen at any time? It can happen at any time. I've seen a really weird case of people who are like 60 getting diagnosed with bipolar, but the most common, like I mentioned, male is early 20s. Obsessional disorder, I mean, it probably wouldn't present this severe, and it would probably be like very specific to something. Let's see. Yes, it is. Sometimes people who are like in a manic episode can look narcissistic because one of the key things that's in Dig Fast is is grandiosity. So it can look like narcissism. Yeah. Can you develop it from environmental, or is it pre-existing? It's pre-existing, but environmental factors can bring it out. Drugs can bring it out. Some certain medications like steroids can bring it out. Adderall can bring it out if it's underlying. Is there treatment for social anxiety? Absolutely. Cognitive behavioral therapy is one of the big ones for social anxiety. Have you ever worked with DBS? I have not. Our program does not have DBS, but I have seen it during a grand rounds. It's very cool. Tips for international students. I think it's definitely harder if you're trying to like apply into med school or like residency after. I would just say make sure you have a mentor. A mentor will make the biggest difference, especially if you're international. I think that makes a huge difference if you have someone who's already like been through the process. Okay, is there a lot of manual dexterity? No, not at all. It's basically like putting the leads on, putting the actual electrodes on, and then just pressing a button through a machine. Not at all. Yes, tons of epigenetics. UT is doing a ton of research on epigenetics. I do think that there's a lot of difficulty with uncertainties. But I think if you love it, you love the uncertainty of it. And when you become really good at diagnosing, I think it's cool when you can kind of like look at a differential and know that it could be two and still kind of treat it in a way that can make them better. Not a lot of objective diagnostic measures just yet, but I will say that once you become really good at it, using the labs, using the data, using family history, using collateral, using everything, you kind of are able to come up with a good diagnosis, even if it's not like for sure their diagnosis. Let's see. Any tips for social anxiety? I would just say make sure that you are utilizing resources. Like, so if you want to do therapy, or group therapy is really great for social anxiety. Kind of challenging yourself. I think people with social anxiety have a really hard time putting themselves in those scenarios, but I think pushing yourself and getting a lot of exposure. There is exposure therapy specifically for social anxiety in group therapy settings. So that might be something, and they're virtual now, so it might even like lessen that anxiety a bit. What's your weekly schedule look like? It varies depending on my rotation. Inpatient, a little bit longer hours. Outpatients like 8 to 5. Consult liaison is 8 to 5. You can work weekends as a psychiatrist, but you don't have to. Love the work-life balance. I personally don't want to work full-time, so I am pursuing acting as a second career. I'm in a few commercials, and I do a lot of like interviews for this local news channel. And so I do want to be able to have both my careers. So that's why I picked it. It's like you can kind of make your week look exactly what you want it to look like. What's the favorite and worst part? My favorite are my patients. I think they're really strong, and I think it makes you stronger when you have a mental health condition or mental health struggle. My worst part, just like I mentioned, like some of the sad things that you see and the situations that you see that you can't change. This one is one of the most interesting cases I saw. But I feel like ECT cases are very interesting. You kind of see someone really sick, like not even talking catatonic, just someone whose brain is not functioning to let them talk and eat, turn around and go back to themselves and walk out of the room, and it's just so cool. Incorporate procedures, absolutely. I do injections, I do LAIs, I do ECT. There's like DBS, there's like all this new stuff coming out that's very procedure based. So I specifically love procedures, so I'm going to be doing them. No, I did not go through as an international student, because I was technically like a Texas resident, because I've lived here for 20 years. But I was considered an international student when applying to med school. So I would just say make sure that you are looking at the requirements and following those. And then, like I said, keep a mentor, someone who's been like applied in the same setting that you're applying, and that's going to make the biggest difference. Let me see what the time is. I don't want to like take y'all's time. Oh, it's 11. I'm so sorry.
You're good. No, you're totally fine. I think it was just some tips on like some different most of the questions were answered, I would think.
Okay.
But thank you so much for your time. This was an amazing presentation. Someone up that you were really calming, and I think that's the perfect way to put it. You really put everyone at ease in our journeys. We're all kind of going through it at the moment. So thank you so much for that.
Yeah, absolutely. If I didn't answer your question, guys, I'm so sorry. Feel free to message me. I love meeting people. I love talking to people. It's probably why I love psychiatry too, because I love people. So feel free to connect with me. I'd be more than happy to help.
Great. And then we're going to go ahead and put your handle in the chat real quick again. So if anyone wants to follow you.